So, current standards and future directions. It's, of course, not so easy to discuss the future. We can at least discuss the issues with standard guidelines and to try to see what can we do in these conditions. I will mostly focus, of course, on the hemodynamic resuscitation, where most of the discussions come. And perhaps one of the things that we may discuss is already this amount of fluids that should be given within a given period of time. And where do these numbers come from? Well, we had a discussion yesterday, and basically what we have are some big numbers, large observational data showing that there is a U-curve. When you give less than 15, you have an increase in mortality. When you give above 45, 20, 50, you have also an increase in mortality. So it seems that, yes, it's a good common denominator than telling that 20 to 30 could be a good number. But these are the data. We do not have better data compared to these, and probably this is something we need to discuss later on. So the good thing with this recommendation is that it makes some emphasis on the need for fluid resuscitation. We should not forget to give fluids in these patients. Also, the amount is somewhat in agreement with observational data, at least for the average number. The bad thing is that there are no strong data, and maybe 15 is better than 20, or 20 is better than 30. We do not know at this time. And of course, the one-size-fits-all is probably a problem there. The bad thing there, in this, the very bad thing in this recommendation is the delay. The delay was here basically for making the people looking over the shoulder of the doctors very happy, so that we have a number and we can have a constraint to say you did bad because indeed you did not give the fluids within that amount of time. But basically what we should think at is to give it as soon as possible. There is no reason to delay therapy in these conditions. The second discussion I would like to have is that just after this initial resuscitation, we recommend then to give additional fluids, which is good, probably, but based on frequent reassessment of hemodynamic status. And this becomes a little bit more fuzzy, because it's, of course, for a guideline, is very difficult, because I don't know exactly what this represents. Before, it was more easy, because we had numbers, and you have to fit with the numbers. These may not be good, but you have to fit with the numbers, which is something relatively easy, because indeed, if you have your young colleague junior at the bedside, you may say, go and have these numbers tomorrow, I will be happy then. Okay. We all know that these numbers were challenged by the different trials that indeed looked at these in a randomized fashion and observed no benefit at the end in terms of mortality. And this, of course, may be the end of the aspect, and this is why indeed is not recommended. And the wording in the rationale is quite interesting, because indeed it is said that the protocol cannot be recommended for its evidence-based, but nevertheless, clinicians still need guidance on how to approach this group of patients. And then the next sentence is a little bit more complicated, because indeed we recommend these patients are viewed as having a medical emergency. Okay, we knew it. That necessitate urgent reassessment and treatment. Okay, but what treatment, what assessment, we do not know. And so this ends up by really something that we will need to develop further, is what will have to be done at the bedside. The first aspect is, should we throw away what we have done up to now? And maybe not, because indeed we need still to look at the trials. And one of the very important factors is that these trials included patients who were already into the target. So this means that the fact of reaching the target was not really tested in these trials. The second point is that these patients were much moderate compared to the same patients we have at the bedside in real life. Because indeed, if we look at the lactate levels, the mortality observed, it's much lower than what is observed in observational trials done at the same time. And by the way, the reverse was exactly in the target of this expected mortality for the level of lactate they observed. And this may perhaps be due to the fact that many patients were seen, but very few patients were included in these trials. And again, I mean, if we look at the admission, it's less than one patient, half a patient, half a patient. This means that basically 6 patients per year in your center will be included. So we are talking here for 6 patients per year. Now, we have much more patients in our centers. There is a heavy selection bias, and this may perhaps explain to some point why the mortality was so low in these patients. And indeed, if you look at this very important figure here, these patients were with shock, not responding to fluids and or high lactate levels. And 20% of these patients in the control group were not admitted to the ICU. These patients were going to dermatology, psychiatry. Okay, very good place for a patient with septic shock not responding to fluids and with a high lactate level. So this basically makes that these were not really patients with septic shock, but 1/5 of the population was not really patient with septic shock, which is something which is, of course, a problem. So the concept probably remains valid. We all agree that the physiology behind it is quite good. Maybe the recipe that was applied was not okay. And what is most important is that patient identification is crucial. By the factors they looked at, 1/5 of the patient could have been seen or perceived as septic shock patient, even though these were not admitted to the ICU after. So this means that we do not have good identification of the patient who may benefit from it. And it's clear that the less severe patients should not be receiving this therapy. So the classical goal-directed therapy may perhaps be applied when we do not have something better to apply. We may accept this, but of course we need to think at something better at the end. So what we have now is something which is we have to look at saturation, heart rate, blood pressure, and so on. And this integrates different variables of tissue perfusion. For this, it's quite good. So the indication of fluids is looked at with the current recommendation. But there is no rigid, of course, follow-up of the bundles, which is probably good also. Again, no strong data, very evasive, and at the end, no clear recommendation, which is perhaps the limitations there. So what do we really recommend at the bedside for our doctors is to look at all these factors here. And these factors are very good probably to indicate fluids. But remember, none of these will indicate that your patient, perhaps with exception with echo, will indicate that these patients will respond to fluid. So these are indications for fluids, not indications of the positive response to fluid. And so we probably need to assess it in a better way and not just blindly give fluids in all these patients. So for the indication for fluids, we indeed have now suggested the use of dynamic indicators. And for this, it's probably good. We have a lot of these. You all know it probably. The best trial looking at the potential benefit on outcome is this trial here from the group from Lyon, showing that indeed there was a more rapid decrease in lactate level and a trend to an improved outcome when these variables were used compared to control. But that's all. So perhaps we need more trials like this to ensure that indeed it may improve outcome and not just better predict the response to fluids and better limit the amount of fluids that are needed in these patients. But perhaps still we should not throw away all the other factors. Perhaps still we need, when we have the possibility to measure, look at the CVP, because statistically speaking, we know that 2/3 of the patient will respond to fluid when CVP is low. And we also know that 2/3 of the patient will not respond to fluid when CVP is high. This is from this meta-analysis here. And again, we have again the same data here showing that most of the patients respond when CVP is low. Most of the patients do not respond when CVP is high. So, of course, the gray zone is quite broad, but nevertheless, it has some value that should not be neglected. And again, prediction is not so bad in some of these trials here. often not coded elsewhere in some other meta-analysis. So it's probably very good to use these dynamic indices, but we need to keep some other possibilities there. And what I do not like here is the as long as hemodynamic factors continue to improve, because this means that we will be chasing the administration of fluid, and we'll continue to give fluids and give fluids, and perhaps the needs are less and less present at this time. And perhaps it's time to look at this trial here. Of course, it's done in Africa. I may say, okay, I don't treat African patients, and the way they treat is quite specific. But nevertheless, I mean, you can see that the sepsis protocol, which included a lot of fluids, was detrimental in these conditions and increased mortality in these conditions. Interestingly, you can look at the protocol, how they did it. They administered 2 liters of fluids, so roughly 30 milliliters per kilogram, but then they followed by an additional 2 liters over subsequent 4 hours. And why? Because. Just because. Because indeed, they were deemed to tolerate it. The only way they did not receive it, it was because they developed desaturation, they were and almost dying from fluids. But if they did not die after 2 liters, then they give an additional 2 liters to ensure that they will die from fluids. And indeed, there was an increase in mortality. But so these patients were reassessed for tolerance, not for the need of fluid. And this is really what we need to have, is to assess whether or not my patient may perhaps benefit from fluids before giving fluids and seeing if he tolerates it or not. And of course, when you look at the facilities here, they have almost no oxygen in these areas, which is something which is, of course, quite disturbing. So the other aspect is perhaps the discussion on other factors like the blood pressure. And of course, for the blood pressure, it's recommended to have 65. And of course, it's based on this big trial here from France. But we all remember that there were some subgroups, and some subgroups benefited from a higher mean arterial pressure to protect the kidney. But we knew also that there were some side effects, because indeed there were more arrhythmias and also a trend to more acute myocardial infarction in that trial. So is it beneficial for all? Maybe not. And so perhaps it's time to go for, again, identification of a patient who may benefit from it. But we do, because we do not have it, because it was just before previous hypertension, maybe we should look at who respond to it and to do a vasopressor trial to look at whether or not there is some improvement. Because when you increase the blood pressure here, you can see that there are some patients who improve the kidney perfusion, but some patients have a deterioration of the kidney perfusion here. So obviously, there is no benefit for some of these patients, and it's better to assess and to stop when not needed, rather than just saying, he was previously hypertensive, so I will give it. When to introduce it, probably early on, and this is no more discussed in the guidelines, and this is probably worrisome, because indeed, experimental trials say that when you introduce relatively early vasopressors, you can also limit the amount of fluids you give in these animals. And delaying vasopressors is also associated with an increased mortality. So, lactate to end up, and indeed we can look at the fact that decreasing lactate is something beneficial. And this trial, among others, indeed shown that decreasing lactate as a target for resuscitation can be something we looked at. And indeed it resulted in a decrease in mortality, not significant for a whole group, but significant at least for the hospital mortality and for the ICU mortality. But hospital mortality is probably quite meaningful in these conditions. And some meta-analyses published here were giving the same results, but also more recent trials were going in the same direction. So this seems to be something very good. And so I would agree that this is something we should do. Perhaps something that still I do not like so much is the fact that they also say we should normalize. It's of course better to have normal value, but we should continue to have a huge therapy to try to absolutely decrease lactate from 2.1 to 1 to 1.1. Maybe at this point it's no more valid if your patient is well for many other things. And so what we would suggest rather than is to really look at other factors and to combine the variables, not only looking at the lactate, but also looking at the capillary refill time, the SCVO2, many other signs of tissue perfusion that can be beneficial in these conditions. And this is why, indeed, I think that basically our resuscitation strategies could go into that direction to try to optimize the different things and not only to look at one single variable. And this is probably something that is not yet taken enough in these different guidelines where we dissect everything and just base one after the other one, the different factors there. And I will skip a few things I had to say on the vasopressors, and I'm waiting for my last slide. So, because I cannot go directly to it, I will have to wait 2 seconds for it. So now it should go to my last slide. And so indeed, what we have seen is that indeed these guidelines have set the scene for a standardized therapeutic approach, which is based on minimal measurements and that benefit most of the patients. And this is really what we need to think at. It benefits most of the patients. We can do better, and that's indeed what we should look at is to implement these refinements, which are based on specific measurements, evaluation of patients, and these should be done at the individual level and look how a patient responds to the therapy in these conditions. With this, I thank you for your attention.